Assalamu alaikum wa rahmatullah. Welcome everybody and good evening for all people who attend this short meeting. In behalf of the Dean of College of Medicine, Dr. Rashid Barada, and Dr. Abdullah Al-Ayyan is under service of the Medical Education Unit. Will present this meeting about the ECG interpretation with Dr. Badr Al-Mahmadi. He is Assistant Professor of Medicine and Consultant Rheumatologist in Majmaah, College of Medicine, Majmaah University. Inshallah, in next 2 to 3 hours we'll present this meeting, and it will be interaction with all attend people. Dr. Badr, you are ready, inshallah, to present this meeting. Dr. Badr with us?
Yes, I'm with you. Can you hear me?
Yes, we hear you. There is no certification for attendance, only this meeting for education purpose. Inshallah, in future, we'll arrange for certification in next meetings. Dr. Badr, you can proceed for your meeting.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. I am so thrilled to see all these numbers coming for this workshop on the ECG interpretation, the way we are supposed to be reading ECGs properly. We'll be going through the normal in ECG, then we're going to touch on the abnormal part. So we can try to practice together how we can practically apply all the rules that I'm going to be talking about. I welcome you all, and I hope, inshallah, all of you will be having a lot of benefit out of this workshop. If there is any question, please put it in the chat box, and inshallah, throughout the workshop, we'll be answering, inshallah, all the questions. Okay, so basically our objectives for this workshop is that we're going to be going through the electrical conduction in the myocardium. We will be talking about the cardiac leads and their locations, ECG shapes, waves, and the conduction intervals. And then we're going to be talking about how to systematically read the ECG. And then we will be touching on some of the abnormal ECGs that might be seen in real life practice, such as the heart blocks, bundle branch blocks, cardiac ischemias, and arrhythmias. So before we start, I would like to recommend this book for all students and interns. This is a simply made book with a lot of illustrations, a lot of easy steps to follow in order to get all the possible information that is required from the sorry. So just give me a second. Let me just. Okay. So this is a really good book if you want to be following a systematic approach for reading any kind of ECG. There are so many other excellent books in the market. So whichever book you think is appropriate for you, you should go ahead and use it. Now, we will start talking about the cardiac conduction system. As you all know, with your medical background, that all the cardiac cells can generate impulses by themselves, but we can always see that the SA node always takes the lead in forming the charge that goes through the cardiac muscle. And the reason for that is the amplitude that is charged of the electrical impulse in the SA node is way larger than any other amplitude that is being charged in the other cardiac cells, and therefore it emits all the other charges around it, and it starts every pulse from that direction. So the pulse starts from the SA node and it goes through the right atrium and the left atrium. And you can see that as soon as the atrium is filled up with a charge, that causes the contraction. Now, we see that in the ECG in the form of waves, and we will be talking about the waves in a minute, but just to focus a bit on the way the conduction goes in the cardiac muscle. So first of all, the right and left atrias are filled up with a charge. That causes a contraction in both, and that shifts all the blood that is filled up in both atrias into the ventricles, and then the electrical impulse goes to the AV node, where it is the junction between the atrias and the ventricles, and that impulse goes from the AV node down to the Purkinje fibers, and then it goes to fill up all the ventricular walls, forming the ventricular contractions. And we will be talking about each of those stages in the ECG waves, but I want you to understand that we have a few phases that we want to be focusing on. The first is filling up of the electrical impulse from the atrias and then forming the contraction, then going down to the AV node, forming the conduction down to the ventricular walls, forming then the ventricular contraction. Now, in terms of the ECG leads, you can see that there are two major planes that the ECG leads are formed on. The first is formed by the sagittal plane, and the second is the coronal plane. We start with the limb leads. We have the right arm, and the left leg, and all of those three will be recording some of the electrical activity that is seen in the cardiac muscle. The rest of the leads that are found in the same plane are the lead 1, 2, and 3. Those are called bipolar leads because they form a positive and negative charge directions in the recordings. The second plane of leads is the precordial or the chest leads, where we see leads going from V1 to V6 in the most commonly used leads in practice. It starts from the fourth intercostal space right to the sternum, and that would be lead V1. And then we go to the left of the sternum, where we find V2, going down to the V3 and V4, going below the fifth intercostal space, and then to the mid-axillary line, we end up with V6. Now, when we see all these leads, we can say that both planes would be forming a two-dimensional image of the heart, and that is very useful for us to be able to see where exactly would the pathology be. So this would be helping us into finding out if there was any problem in the conduction of the electrical activity in the heart, and it would also let us find out if there was any pathology at a certain point in the cardiac muscle. Now, to understand how the direction of the leads would go, we should be talking first about the normal cardiac axis. You've gone through the physics, and you've seen that there was always, when you have different forces, you would find that there was a net force that combines all forces in a single direction, and that's exactly what happens in the normal axis. We can see that the majority of the conduction goes from the AV node, from the SA node to the AV node down to the ventricles, and then in the ventricles we have different directed charges, but the majority of the charge will be found going towards the left ventricle, and therefore the normal cardiac axis is usually found next to lead 2, and we will be seeing that it is a form of a range more than a single line. Now, these are the waves that we usually see in the ECG strip. We start with the P wave, which represents the atrial depolarization, which means the atrial contractions. So as soon as the SA node starts forming enough impulse, it goes through the atrial walls, forming a charge that would be causing a full contraction in both atrias. Now, you have to keep in mind that the P wave stands for 2 waves instead of 1, because we have a single contraction that goes into the right atria, and another contraction that goes in the left atrium. But because they are synchronous and they happen almost at the same time, we can see them as a single wave where they both waves do overlap each other, and that's how we see that they are in a single wave. And then we have a pause, which is represented here by the PR segment. And this pause is what we see when the electrical impulse goes to the AV node. There is a slight pause of about 0.1 second. And then the QRS complex starts forming, which is the depolarization of the ventricles, where the electrical impulse travels from the AV node down the Purkinje fibers to the ventricular walls, forming the ventricular contraction. And then finally, we see the ventricular repolarization, where the ventricles relax and the positive charge turns into a negative charge. Okay, moving on to the this is exactly what we have been going through. The atrial depolarization usually stands for the activation of the atrias, and then the QRS complex represents the activation of the ventricles, and then we have the recovery wave, where the charges, the positive charges in the ventricular walls turns into a negative charge, and that's how we find the T wave. Now, some of the ECGs, we might see a U wave also coming at the end of it, and usually that stands for the recovery of the also the Purkinje fibers. Okay, so it's very important for us to also know the interval where each of those waves starts and each of those waves end, because that would give us an idea about the timing that it had taken for the electrical charge to move from one part of the heart to the other. You can see that the PR segment is usually measured with a distance or a duration of about 3 to 5 small squares, where the QRS complex is about 1 to 3 small squares. And then we have the ST segment followed by the QT interval, which usually takes a longer time. Now, each of those would be representing a certain pathology if they were shorter than normal or longer than normal. And at the end, we also see the RR interval, where it represents the time taken for the heart to develop 2 full cardiac beats. So when we go through the ECG, there are different ways of reading the ECGs. One of them is going through them systematically in some of the mnemonics. I have been using this way for years, and it had proven that most of the time you won't be able to miss any pathology if you go through them this way. So we start with 3 R's and then 3 C's, and then finally we end up with 2 T's. The first R is the rhythm. So you ask yourself, is that a sinus rhythm or not? And based on that, you can say if the patient, the cardiac muscle had started the impulse from the SA node, or has the impulse had started from a different site. And then we talk about the regularity. Is the rhythm regular or is it irregular? And we will be talking in details about this in a minute. And then the heart rate, which should be calculated based on the regularity of the rhythm. And then we talk about the conduction intervals and how long had each interval take in order for it to finish. And then we will be going through the cardiac axis. Is it a normal cardiac axis? Is there any left cardiac axis deviation, or is there any right cardiac deviation? And then we will be talking about the shapes of the QRS complexes and the meanings behind the different shapes. And then we will finalize with the 2 T's. The first T is the ST segment. Is the ST segment isoelectric, which means that it is at the same isoelectric line as the PR interval, or is it elevated way beyond it, or was it depressed when seen in different leads? And then we finalize with the T wave in terms of its shape. Is it normally shaped or is it abnormally shaped? And what are the reasons behind each? Okay, so when we talk about the rhythm, the only question that we're looking for an answer for is there any P wave? So if you see a P wave, it means that this is a sinus rhythm. If you don't see a P wave, it means that the impulse had started from a site that is different from the SA node, which is a non-sinus rhythm. When we talk about the regularity, we basically what we mean is the duration between each beat and the next similar to any other beat and its followers, which means that should there be any change between the duration of the interval between the beats, or are they fixed in a certain timing throughout the cardiac cycle? So one way to find this out is to count the small number of squares between the R waves, and then we compare them with other duration of RR intervals. So for example, if we see it here, you can see if we start here, you can count one big square, 2 and 3 and almost a quarter. So we have 3 1/4 big squares. When we want to compare that to, for example, here we have 1, 2, 3, and another quarter. So if we go through different RR intervals and you see that the duration is similar in most of the time, this means that this is a regular rhythm. Another way of doing that is using a caliper, where you put both points of the caliper on the R waves, on 2 different R waves, and then you start comparing them with other RR intervals. And if you see that both pins would be pointing at the tips of the RR waves, this means that this is a regular rhythm. If you see that it goes way away from the pin of the caliper, it means that the rhythm is an irregular rhythm. Another method that is commonly used in clinical practice is using the paper and pen. You just simply take a small piece of paper and you mark 2 of the R waves, as you can see here, and then you start comparing with other R waves. If all R waves would be fitted on both lines, it means that you have a regular rhythm. If you don't see them fitting in all lines, it means that you are seeing an ECG with an irregular rhythm. Now, this is important because it will determine the way we calculate the rate. Now, we have to understand when we talk about the rate that there is a fixed time where the speed of the ECG strip would be moving into recording the ECG beats. And you have each small square would be represented by a 0.04 seconds. A large square would be about 0.2 seconds. So for each 5 large squares, you will have a single second elapsed from the time of recording. And this is very important for us to find out how much would be the heart rate in the ECG. Now, this is the reason why I was saying that the regularity is very important for us to determine before we go into calculating the rate. Because if it is a regular rate, a simple way of calculating the rate is counting the number of big squares between the R's and then dividing 300 by that number. So you can see that there is 1 big square, 2, 3, 4. So 300 divided by 4 equals to a heart rate of 75 beats per minute. Now, the normal heart rate is 60 to 100, which means that in squares, it's about 5 to 3 big squares. That is the acceptable number of squares between the R's to say that this patient has a normal heart rate. And you can also apply it here. We have 1, 2, 3, 4 big squares. If that is a regular rhythm, then 300 divided by 4 is 75. Now, if you are faced with an irregular rate, That method of calculating the cardiac rate is not accurate, because you might be faced with short intervals like this, where you would assume that there is tachycardia, and then you would be having longer intervals like this, where you might say that this is bradycardia. So the best way to do that is to take the sum of a 6 seconds rhythm and find out as an average. You would take it for that period of time, and then that would be your irregular cardiac rate. So in order for us to do that, we calculate the number of R waves in 6 seconds, and then we multiply that by 10 in order for us to find out how many beats we would be expecting in a full 60 seconds minute. So as we've said, 1 large square is equal to 0.2 seconds. 5 large squares are equal to 1 whole second. So 6 seconds would be equal to 30 large squares. So the way we do that is, this is an example where we can apply this method. So we count 30 big squares, and we can see in this ECG strip that we have 1, 2, 3 down to 30 big squares, and then we count how many R waves are we seeing in those 30 squares, and you can see that we have 14 R waves in these 30 big squares. 14 times 10 is 140, so the cardiac rate for this patient is 140 beats per minute. Now, if anyone can tell me what is the heart rate for this patient? We won't be doing any voting for this, but if you can just put it in the chat, and I'll have a look at it. Okay, so most of you have said 100. Some of you have said 180. I have not put 180 in the choices. Basically either 60, 80, 110, or 150. So in order for us to find this out, first we have to see and answer the first question: is this a regular rhythm or an irregular rhythm? So if we go through 2 R waves and see how many squares are in each. So this is one, this is the second one. There's about 3 squares here. We can see that from here to here there are 2 squares. We can see that from here to here there are 3 big squares. So this is basically an irregular rhythm. So the way to see to find out what is the cardiac rate for this patient, we start counting 30 squares. So if we can start counting from here, for example. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, and 30. So now we have seen 30 squares. Okay, so we should be counting how many R waves are we seeing in these 30 squares. So going back, we'll be counting 1 here, 2, 3, 4, 5, 6, 7, 8, 9, 10, and 11. So we have 11 R waves in these 30 squares. Those 30 squares will be representing 6 seconds. So in order to say how many R waves we would be expecting in 60 seconds, we multiply by the number of R waves found in those 6 seconds by 10, which is 110, because we have here 11 R waves in the first 6 seconds. Okay, so moving on to the conduction intervals. It's very important for us to determine how long would each interval take in order to say, would there be any kind of pathology behind the conduction at that certain site? we can see that the PR wave, the PR interval, sorry, usually takes about 3 to 5 small squares. The QRS would usually take about 1 to 3 or 2 to 3 small squares. The QT interval would be taken a bit longer, about 0.35 to 0.43 seconds. And then the RR interval in a normal cardiac patient would be about 3 to 5 large squares, which would be representing 60 to 100 beats per minute. Now, moving on to the conduction intervals. So when we talk about the conduction intervals, this is one of the examples that we usually see in the QRS complex when we see how long had the QRS complex taken in order for it to start and finish. And you can see here that there is a wide interval in the QRS. Here we see that this is a narrow complex QRS, and this is the normal. You can see that the interval here barely covers 1 small square. We can see that this is almost 5 small squares, which is way larger, or even more, which is way larger than the normally expected interval duration. And then in the normal QRS, we can see that it had taken about 2 to 3 small squares. Now, this is the second C, or the third C, which is the cardiac axis. Now, as we have talked about before, we start from the heart, from the SA node, going down to the AV node, then going through the right and left ventricles. So basically, the direction of the current will be starting from the right upper corner of the heart, going down to the left lower corner. And for that, there is a range of accepted normal range for the cardiac axis. Basically, that starts from the site of the AVL lead down to the AVF lead. So any current that goes through this range of field would be considered as a normal axis. Now, in terms of ECG, there are different ways for us to find out if the patient does have a normal cardiac axis, or they will be having some deviation either to the left or the right. One of them is seeing the, okay, so we will be just going a little bit back to one of the ECGs. So basically, any current that goes towards a certain lead would be charged as a positive lead. Any current that is going away from that lead would be charged as a negative lead. When we say a positive lead, we mean a dominant R wave. So this lead 1 would be represented by a positive current, where in AVR, we would see that there is a dominance of the S wave, which means that this is a negative lead, because usually the current would be moving away from the AVR towards the AVL, AVF, and other leads at the left side of the heart. So for that, we would be expecting that the AVR is usually on the negative side. The AVL could be positive or negative in some of those leads. Okay, so in order to elaborate more about this, let's say that the electrical current is going through this line. So if the cardiac axis for that patient is this particularly single line, it means that it goes within the field that is considered as normal, and that would be considered as a normal lead. So how do we read that in ECG? Basically, if the current goes, okay, so let's say, for example, the current goes exactly on lead 1. Anything that is around lead 1 would be charged with a positive charge. AVR would be, on the other hand, away from the direction of the cardiac axis. So usually we would see that this would be charged on a negative charge, which means that the S wave would be dominant. Here we would see that the R wave would be dominant. Okay, so what about the other leads? How would they be charged? the more we go away from the exact line of the current, the more negativity we would be getting and less positivity we would be going for. So, for example, in lead 2, you would see that there will be a big R wave and a smaller S wave. You might not see any S wave here in lead 1 because the current is 100% positive, which means that there would be no S wave and all the current would be positive current. So we would be seeing a positive R wave. The more we go away from the exact line of the current, the more we would get an increase in the S wave and a decrease in the R wave, until we find a spot where we see that the R wave is equal to the S wave. And that's basically when we go 90 degrees away from the line of the current, which is in this example, it's the AVF. So we're expecting if the current goes exactly on the line of lead 1, we would be expecting on AVF the R wave to equal the S wave. Okay, and then as long as we go away from that lead, we would start to see some negative leads, which means that the S wave would be way bigger than the R wave. And we will be talking about that in a minute when we go through the example. So this is one of the ways we find out how is the lead positive or negative. So the second question goes is, how would we be able to find out where exactly is the cardiac axis? Now, if I say to you that the lead 1 is expected usually to be positive because it is usually within the normal cardiac axis. At the same time, we would also be expecting lead 2 to be also positive because it also goes within the range of the cardiac axis. But sometimes, as we have said here, that if you go 90 degrees away from the direction of the current, you start finding if, for example, you are looking at lead 3 and the current, it goes exactly on the line of lead 1, then we will be expecting lead 3 to be negative more than positive, which means that there will be a dominant S wave at lead 3. So how would we find out where exactly would the current go, and would it be within the normal axis range or would it be away from the normal axis range? So basically, if we look at lead 1 and lead 2, that would give us a good idea about where exactly is the current going. Is it within the normal axis or is it away from the cardiac axis, from the normal cardiac axis? So let's take examples on this graph. If you take a line here, which is within the normal cardiac axis, we would be expecting lead 1 to be positive. We would be expecting AVL to be positive. But if you look at AVF, it's going to be negative because the angle is way bigger than 90 degrees. But how about lead 2? Would it be positive or negative? You'll be able to say that lead 2 would also be positive because lead 2 goes into the negative side as a 90 degrees angle from lead 2 if the current goes on this green area. Anything below this green area will be giving us a positive lead 2. So lead 2 will be covering this line for us. If lead 2 goes negative, it means that the current is going away from this line. And if it goes away, it means that the cardiac axis have deviated. So lead 2 would be guarding this line for us. At the same time, lead 1 would be also guarding this line for us, because if we apply the same rule, we have a 90 degrees angle from here. So anything that is beyond this line, anything that is beyond AVF would give us a negative lead 1. So if we see that lead 1 is negative, it means that the current has crossed this line into the deviation line, to the deviation area. Okay? So we usually look at lead 1 and we lead 2. If both of them are positive, it means that we are in the normal cardiac axis. If both of them are positive, it means that the line is either here, 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 or here. If one of them is negative, then it means that the cardiac axis is going away from that negative lead. So if one is negative, it means that the line is at this area, which is more than 90 degrees away from lead 1. Of course, lead 2 could be positive if it's on this area. So the first rule that we have to understand is that if both of them are positive, it means that we are in the normal cardiac axis. If one of them is negative, it means that there is a deviation. Now, the second question is that we ask ourselves, where exactly is it going? Is it going towards the left axis deviation or towards the right axis deviation? At that moment, we look at both leads and we look which one of them is negative. So if lead 1 is negative, it means that it's going through this area. It's going away from lead 1. Because if it's here, we will be expecting lead 1 to be still positive. Okay, so if lead 1 is positive, but lead 2 is negative, it means that the axis is going away from this line, because this line will be represented by a 90 degrees angle with the lead 2. So anything away from this line would give us a negative lead 2. So in order for us to determine what is the cardiac axis, we usually look at lead 1 and lead 2 to make things easier. If both of them are positive, this is a normal axis. If this lead 1 is positive, lead 2 is negative, it means that we have a left axis deviation. On the other hand, if lead 1 is negative and lead 2 is positive, then we are seeing an axis deviation at this region. If you have any questions about this, I will go through it later on. Now, going for the final C, now we have mentioned, let's wrap it up. We have 3 R's. The first R is the rhythm. The second R is the regularity. The third R is the rate. And then we go to the 3 C's. We have the conduction intervals. We have the cardiac axis. And then we go through the complexes. When we go to the complexes, we talk about the QRS complex and how is it shaped? Is it normally shaped or is it abnormally shaped? And you can see here that there are different ways that we may see the QRS complexes illustrated. You can see here that there is a dominance of the R wave, and this is what I was saying about a positive lead. If you see dominance of the R wave, which means that the R wave is bigger than the S wave, this would say to us that this is a positive lead. But if you see that the dominance is for the S wave, you can see that the S wave is way larger than the R wave, which means that this is a negative lead and this is a positive lead. This is the way we see any positivity or negativity in the leads, and that would give us an idea about the cardiac axis. So this is one way of seeing it. The second is checking if there was any additional waves in the QRS complex, such as a Q wave. Usually, if the Q wave is more than a third of the amplitude of an R wave, this would be considered as a pathological Q wave. Another way of seeing the QRS complex is when we see that it has a double chin or a rabbit ear pattern in the QRS complex, where we are seeing 2 distinct R waves instead of 1. And we can see that in some pathological conditions, such as the bundle branch blocks. And we're going to go about that later on. So this is one of the examples that we see the QRS complexes changing. in the right and left bundle branch blocks. As we have talked about before, if you remember, when we said that both atrias and ventricles contract separately, but when we see them in the ECG, we see that both of those contractions happen at the same time, giving us one P wave, where it is actually two waves, but they are overlapping each other. And the same thing goes for both ventricles. Both of them would be contracting separately, but we usually see them as a single R wave. And the reason behind that is that the timing of the contraction usually would be happening simultaneously at the same time. But in some conditions that we will go through later, we see that there would be some delay in forming a full charge in one of the ventricles, and that separates both R waves for us. So we see a first R wave where one of the ventricles contracts, and then the amplitude goes down, and then the amplitude again goes up when the second ventricle starts charging and starts forming its full contraction. Now, going to the final two T's in the steps that we are going to read every ECG with. The first T is the ST segment. In the ST segment, our only question is it elevated or is it depressed or is it isoelectric? So how do we know what is the marker that we should go with in order to say if it was elevated or depressed? We always look at the PR interval, and we would be considering this line the isoelectric line. So we always compare this line to it. If there was an almost equal line at the other side, we would say that this is an isoelectric ST segment where there would be no ST segment elevation or depression. But you can see on the second example, this is the PR interval, and you can see that this line is way above the line of the ST segment, which means that there is a significant ST depression in this wave. And at the third example, we also compare to the PR segment, and we see that the ST segment have been significantly elevated, and we see that in cases of myocardial infarction. The final T is the shape or the morphology of the T wave, and we can see that there are different shapes that we might see the T wave in. First of all, we normally see the T wave as an everted T wave in most of the leads, apart from lead AVR and V1 and lead V1, where we usually see them inverted. Other examples of a dysmorphic T wave are cases of hyperkalemia, where we see a tinted T wave. We can see that also in ischemia. One of the changes that we may see in the T wave is the T wave inversion in leads that are not supposed to be seeing any T wave inversion. Okay, so we will be taking this ECG as an example. And if there is any, okay, so I will go through this ECG first as an example. We will go through all the steps as we have talked about, and then I will give you more ECGs for you to look at and find out if you can apply all the same steps on it. So the first question that we ask ourselves in the first 3 R's is this a sinus rhythm? The first R is rhythm. So in order to say, is this a sinus rhythm or not, we look for any P waves. So if you see P waves like these here, it means that these are representing a sinus rhythm. So the second R would be, is this a regular rhythm or an irregular rhythm? Now for this one, I will be using the first method, which is the number of large squares between the R and R. If we take these two, for example, we say 1, 2, 3, and almost 4. And then we take another 2 here, here, and here. 1, 2, 3, and almost 4. And we can also take here almost 1, 2, 3, and 4. So basically, we are seeing a regular rhythm. So if we see a regular rhythm, the second question is, what is the heart rate? Now, as we have said before, if it's a regular rhythm, we divide 300 by the number of large squares between the two R's. So if we say that there are 4 large squares here between the R's, then it is 300 divided by 4, which means that the heart rate is 75. Now, the third, okay, so we've said the rhythm, the regularity, and the rate. Now we go to the C's, the 3 C's. The first C is the conduction intervals. So if you can look closely into the PR interval here, you can see that it starts from the beginning of the P wave until the beginning of the QRS complex. And we can see that there are about 3 small squares, which is the normal range for the PR interval. When we look at the Q wave, for example, here, the QRS, sorry, you will see that it starts from here and it ends here, and that's about 2 small squares, which is also within the normal range for the QRS complex. Okay, so going to the second C, which is the cardiac axis. So as we've said, in the cardiac axis, we basically look at lead 1 and lead 2. Now we can see that lead 1 is positive because we have a dominant R wave, and we can also see that lead 2 is also positive because it comes with a dominant R wave, which means that the cardiac axis is a normal cardiac axis. As an example of negative leads, we can see that V1 is negative, V2 is also negative because it has a dominant S wave instead of a dominant R wave. Now, the last and final C is the complexes, the shape of the QRS complexes. Now, you can see here, here, and here. We can see other examples here. We can see that all the QRS complexes look normal in terms of its shape, which means that the QRS complexes are fine. Now, for the final 2 T's, we start with the ST segment. We can take this, for example, ST segment. We compare it with the PR interval here and the ST segment here. We can see that they are both on the same isoelectric line. You can go also on here. This is the PR interval. This is the ST segment. They are also at the same line here, PR interval and ST segment. They are also on the same line. So this means that the ST segment is isoelectric or normal. And finally, we go for the T wave. Now, you can look at the T wave here. You can look at it here. It doesn't look tinted, and it doesn't look that it has any biphasic way, and it is also not inverted in the leads that it is supposed to be everted in. So as a final diagnosis for this ECG, this is a normal sinus rhythm ECG with no pathology. So it's good for you to see the normal to know the abnormal. Now, this is the way we should be looking at each ECG. If you follow all these steps, 3 R's, 3 C's, and 2 T's, you should not be missing any pathology that you might be seeing in the ECG. Now, one of the pathologies that you might see here is the shapes of the waves. So let's start again with the 3 R's, the rhythm. Does it look sinus or it doesn't? So we can say that this is a P wave, so this is a sinus rhythm. The second question is this a regular rhythm or not? Roughly, we would say that there are 3 squares, so this is a regular rhythm. Going for the third R, is this what is the rate in this kind of situation? We divide 300 by 3, that gives us a rate of 100 beats per minute, and so on. So in each of the following ECGs, I want you to start applying all these steps and find out what kind of pathology you might be picking up going through those steps. So if you can kindly look at this ECG and tell me if you see any pathology in it. Remember the 3 R's, 3 C's, and 2 T's. Okay, thank you for all those who have answered. I will go through their comments. So if you say that this is an irregular rhythm, you might be right, because if we take as an example these 2 R's and see how many big squares there are in between them, 1, 2, and 3. And if you look at it, for example, here, between these 2 S waves or these 2 R waves, it's the same. So we can count 1, 2, 3, and 4 big squares. So this is an irregular rhythm. This is excellent. The second comment was about a tinted T wave. Basically, the tinted T wave would be way larger than this. This is the way we see a tinted T wave. So you are right in terms of shape, but in terms of amplitude, usually we see that this is even larger. One of the participants have said that there is no P wave. You can see the P wave here, you can see it here. So make it a rule, if you don't see the P wave in one of those leads, look in the other leads. Go through the strip as a whole. You might miss the P wave, as for example, here we might not be seeing a proper P wave, but if you see in other beats, we can see that the P wave is visible. So don't make your judgment on a single wave. Go through the strip in order to say if this is a proper absence of P wave. Okay, so one have also said about the ST segment elevation. Well, there is no ST segment elevation. You can see here and here, they are both level at the same level. This is the PR interval. This is the ST segment. They are all on the same line. So there is no ST segment elevation at this point. And one have also commented about the axis. Going for the axis, we look at lead 1 and we go for lead 2. If this one is positive, this one is positive. And so this means that this is a normal axis. There is no deviation, neither to the left or the right. Okay, so go through the steps quickly and tell me what obvious abnormality you might see and pick up in this ECG. Okay, so all right, so some of you have mentioned that there is no P wave in those leads, but we can see that there is a slight bump. Sorry. There is a slight bump here. You can see a bump here. You can also see it here. sometimes, and bear this in mind, sometimes in tachycardia, you might see that there is an absent P wave or an absent T wave. It's basically not that, but waves usually overlap each other when the timing is small, so there won't be enough time for the waves to be shown distinctively from other waves. So go through the strip again, try to see if there was absence of P wave or not, and you can see that there are different sites where we see that the P wave is present. Now look at lead 1 and lead 2 again for the cardiac axis. You can see that lead 1 is positive because the R wave is dominant, and lead 2 is negative because the S wave is dominant. So if you go back to the circle that you saw for the normal axis range, let's say, where would we see the axis if lead 2 would be negative? It means that the current charge is moving away from lead 2 and it's going towards lead 1, which means if we go back to the line here, okay. So this is negative and this is positive. It means that the charge is going away from this area. You won't be seeing it in this area, but you will be seeing it anywhere around this area. Why? Because this has this area only. Because up to this line, any charge in this range would give us a positive lead 2. So if lead 2 is negative, it means that the normal axis should be around here, especially because lead 1 is also positive, because this covers the same positive range for lead 1. So this is a left axis deviation. Thank you for the ones who answered this correctly. Okay, so how about this one? Okay, thank you for the ones who have answered. Your answers are correct. So we can see that, okay, so let's go through them in the systematic way that we have started with. We'll go for the 3 R's. First of all, do we see a P wave? There is a P wave here. There is a P wave here. There is a P wave here. So this is a sinus rhythm. Second question is this a regular rhythm or an irregular rhythm? You see, this is about 2.5 squares. This is about 2.5 squares. Here, about 2.5 squares. So this is a regular rhythm. The third question is, what is the heart rate? So if we go for the regular rate calculation, we would say 300 divided by the number of squares between any 2 R's. So that is roughly, if we say 2 to 3 squares, which is 2.5. So 2 squares would be represented by 150. 3 squares would be represented by a heart rate of 100. So it's basically between them. It's around 125. If you have a calculator, you'll be able to find it more accurately, but 300 divided by 2.5 is around 125 beats per minute. So this is considered as tachycardia because the normal heart rate is 60 to 100 beats per minute. Now, some of you have mentioned that this could be a tinted T wave. I would not say that this is not. So this is possibly could be a tinted T wave, but bear in mind the patient's history in order to say if this is a significantly elevated tinted T wave. Usually in the tinted T wave, the amplitude of a T wave will be higher than this. We will be seeing it similar to the amplitude of the QRS complexes in most of the time. Okay, so what do you think is the problem here? Okay, now for this, I want you to go through the steps. Because if you, most of you are saying bradycardia, but if you look closely into it, you might pick up some other problems. Okay, so don't jump into diagnosis. I just want you to mention what kind of abnormalities you're seeing in these waves. Okay, excellent. All right, so let's go through them. First of all, are we seeing any P waves? This is a P wave. Oh, sorry. This is a P wave. There's another P wave here. There's a third P wave here. There's another P wave there. Okay, so scanning through the strip, we will see that there are P waves. Now, the second question is, for the P waves, are we seeing a QRS complex following each P wave? You can see that there's another P wave here, another P wave here, another P wave here, that is not followed by a QRS complex. You can see it clearly here. So we have 1 and 2 P waves before seeing the next QRS complex. So this is an abnormality. We'll talk about those abnormalities later. I just want you to pick up the different abnormalities before we discuss what kind of pathology we'll be seeing. So this is a sinus rhythm, that's first. The second is this a regular or an irregular rhythm? Okay, so let's count between the large R waves, how many large squares between them. If we say like 1, 2, 3, 4, 5, 6, 7, 8, 9. So this is for sure bradycardia, because we've said that for it to be in the normal range, it should be between 3 and 5 large squares. So anything more than 5 squares goes into the bradycardia section. If you want to calculate what exactly is the heart rate, you divide 300 divided by the number of large squares here, and you'll find out what is the heart rate. Okay, so the third question is, we finished the 3 R's, we're going to the 3 C's. The first C is the cardiac access, let's say. So we say this is a positive lead, lead 2 and a positive lead 1. So this is a normal cardiac access. The second C is the cardiac intervals. So let's say from the beginning of the P wave until the beginning of the R wave, this is the PR interval, it's about 5 small squares. So that is considered as a normal PR interval. Keep in mind that there is another P wave here with no QRS complex, and we're going to go into this part in a minute. The second is the interval of the QRS complex. You can see that it's about 2 small squares, which is also normal. Okay, so the final C is the shape of the QRS complex. And what do you think of that? Do you think the shape of the QRS complex is normal in all leads? What do you think of this shape? This shape? Would you be considering those as normal QRS complex shapes? Let me see the chat. Okay, excellent. So this is why I want you to go through the steps every time you see an ECG. Most of you have said bradycardia, which is correct, but that doesn't mean that you have picked up all the abnormalities in the ECG. So you have to go through the steps to find out if there was any other pathology. So we can see that this is an abnormally shaped QRS complex. This is an abnormally shaped QRS complex. And we will talk about this kind of change later on. Now, the other problem that we're seeing is the absence of the QRS complex after every second P wave. And that takes us to the next part of this workshop, which is the heart blocks. Okay, so before we start with the heart blocks, is there any question? I need you to understand the abnormal, the normal to interpret the abnormal. Okay. All right, so now let's start with the heart blocks. Basically, what happens in the heart blocks is a kind of delay in the conduction of the impulses, starting from the SA node down to the AV node, and then the Purkinje fibers forming the full ventricular contraction. And that kind of delay usually comes with some kind of pathology in the cardiac muscle, whether it is a metabolic pathology or a scar secondary to cardiac ischemia, where the tissue have been scarred and fibrosed, and that makes it more difficult for the tissue to transmit all the impulses the way it used to before that kind of accident. So in order to divide the heart blocks, we have 3 degrees for the heart block. We start with the first degree heart block. Basically what we see in this first degree is a constant delay or constant prolongation in the PR interval, which means that every P wave is followed by more than 5 small squares in the PR interval before we see the beginning of the QRS complex. So that's the only thing that we see in the first degree heart block. Usually that is found when we see a pathology in the AV node, because the AV node is responsible for that delay. Usually the delay takes about 0.1 second, but if it takes longer than that, it means that there is some kind of pathology here that have made this kind of delay in the conduction of the electrical impulse. So the first degree heart block is represented by a fixed delay or a fixed prolongation in the PR interval. And that's it. We don't see any other pathology. Moving on to the second degree heart block, we have two types. The first type is Mobitz type 1 or Winke-Bach, and the second one is Mobitz type 2, where we have a 2-to-1, 3-to-1, or 4-to-1 cardiac block. Now, in the second degree, first Mobitz type 1, what we usually see here is a progressive prolongation in the PR interval, followed by a missed beat. So again, we see that this is a normal PR interval. The second P comes with a longer PR interval. The third P comes with a longer PR interval. So from one to the other, we see that there is progressive prolongation in the PR interval. And then the final one comes with no QRS complex. And then the same cycle repeats itself again and again. So in the second degree Mobitz type 1, we see progressive prolongation in the PR interval followed by a missed QRS complex. In the second degree Mobitz type 2, on the other hand, we see a fixed ratio of pattern. It may come as 2-to-1, 3-to-1, or 4-to-1, and that means 2 P waves for 1 QRS. 2 P waves for 1 QRS. So we don't see any prolongation, progressive prolongation in the PR interval. What we see is a fixed pattern of 2 P waves to 1 QRS, 2 P waves to 1 QRS. And we can also see 3-to-1 or 4-to-1, which means 3 P waves and then 1 QRS, or 4 P waves and then 1 QRS. For the final heart block, the third degree heart block, there would be complete dissociation between the atrias and the ventricles, which means that this area has its own rhythm and this area has its own rhythm. This area is forming its own contractions and impulses, and this area is having its own contractions and impulses. There is no kind of connection between the two areas. And with that, we see the rhythm different. There's a difference in the rhythm between the atrias and the ventricles. We can see that there is no relationship between the P waves and the QRSs. We can see a P wave followed by a gap and then a QRS that is not preceded by any P wave. We can see another P wave right after the QRS. We can see another P wave here without any QRS, and then the QRS comes by itself. And then we can see 1 P wave, 2 P waves, 3 P waves, and then we see another QRS. So we can see that there is complete dissociation between the two contractions. So there is no kind of relationship that you can establish between the P waves and the QRS complexes. You can see in the second degree, type 1 and type 2, there is a relationship between the P waves and the QRS complexes. There's a pattern that you can form looking at the strip. But looking at the third degree, there will be no kind of pattern that you can come up whatsoever. Another way of looking at it is dividing the heart blocks into constant PR intervals and variable PR intervals. So in the constant PR intervals, going again, this comes with the first degree heart block where we see fixed prolongation in the PR interval. So it's not progressive like the one we see in the second degree heart block where we see progressive prolongation followed by a missed beat. No, there would be a fixed PR interval for all the strip, followed of course by a QRS complex every time. The second degree type 1, we'll see that it is variable because the PR interval changes from one beat to the other. It gets longer, longer, longer until it comes too long for the QRS complex to form. And then the same cycle repeats itself again. Another constant PR interval would be seen with the second degree type 2, where we see 2 to 1 or 1, 2, 3, 3 to 1 P waves to QRS complexes. So here, there will be no change in the interval between the P's and the R's, but what we see here is a constant number of P waves preceding each R wave. So in this example, we can say that this is a 3, 1, 2, 3 to 1. So this is a 3 to 1 ratio. And finally, the third degree hard block, which comes with a variable PR interval, but there wouldn't be any pattern. There would not be any pattern that you can come up with similar to the second degree type 1. It is, yes, variable, but there will be no specific pattern that you might see. You can see like one P wave followed by a QRS complex, and then two P waves followed by the QRS complex, and then maybe 5 P waves followed up by a QRS complex, and then no P waves, and then another QRS complex. So there is complete dissociation, and there is no kind of pattern between the P waves and the QRS complexes. So based on what you have heard, could you tell me what kind of hard block are we seeing here? Excellent. So all of you have answered correct. This is a complete heart block or a third degree heart block. And the reason for that, you can see that here, for example, we have one P wave, 2, 3, 4, and then a QRS, followed by 1, 2, and then QRS, followed by 1, 2, QRS, and then 1, 2, 3, 4, and then QRS. So you don't see that there's any specific pattern between the P waves and the QRS complexes, which means that this is a complete dissociation between the two waves, which means that this is a complete heart block or a third degree heart block. So what about this one? What do you think is this heart block? What type do you think this is? Okay, thank you for answering correctly. Now, another point that you have to keep in mind, when we're looking at the strip for a rhythm or a certain pattern, the best way to look at it is to look at the lines that come below all those leads. So you can see the first line here, second line, and third line usually cover all the leads that we use for measuring all the different amplitudes in the cardiac muscle. And then below that, usually what we see is one line, but you can see in this strip that we have 3 lines. Each line represents one single lead. And this is very important because sometimes when we're changing from one lead, like for example in this line, when we're changing from lead 1 to AVR, we might be looking at some activity and we don't know, is that a P wave? Is that a QRS complex? Is that a T wave? So that might make us get some mixed results. But for us to maybe be sure that there is no possible errors in what we're seeing, we usually look at a single lead rhythm, like this one here. So we can see here in lead 2, there is no change in the lead whatsoever from start to finish. And this would be a good lead for us to see the regularity. This would also be a good lead for us to see if there's any issues in the pattern, if there's any possible cardiac blocks. Because here there would be no change between the leads, which means that if we see some changes, we would be able to say what kind of changes we will be looking at. So if I want you to see any heart blocks, I would ask you to look at those 3 lines. Let me see what kind of answers you've come up with. Okay, so most of you have said this is a first degree block, which I agree with, because you can see here that the PR interval is longer than 5 small squares, and that is equal for here, equal for here. So we're seeing like almost 2.5 big squares for each PR interval, which means, and we don't see any other pathology, which means that this is a first degree heart block. What about this one? So to cut it short, this is a second degree Mobitz type 2, 3 to 1 heart block, because we can see 1 P wave, 2 P waves, 3 P waves, followed by a QRS complex. But the other condition that it needs to fulfill in order to say that this is a second degree heart block, not a third degree, is that we have to see the same pattern repeating itself again. So we can also see it here, 1, 2, 3, and then a QRS complex, 1, 2, 3, and then a QRS complex. So there is a pattern here, which means that this is a second degree Mobitz type 2 heart block of a ratio of 3 to 1. If we see that this is 1, 2, 3, and then here's 1, and then here's 5, this means that we're facing a complete heart block instead of that. So in second degree heart block and in first degree heart block, we always see a similar pattern. In third degree, we see no dissociation, and the shapes would be different from one cycle to the other. Okay, before we move on, if there's any question about this. Okay, so there was a question about the importance of the ratio. Basically, the ratio would let us know if we're seeing a second or a first degree heart block, because if you see that each P wave is followed by a QRS complex, we are either seeing a first degree heart block or a second degree Mobitz type 1. But if we see more than one P wave before the QRS complex, we're either seeing a Mobitz type 2 or a complete heart block. And that depends on the pattern. If the pattern is fixed, or there will be no dissociation. There is another question: what if lead 1 and lead 2 were all negative? This is a good question. Okay, let's go back here. Okay. So let's assume that lead 2 is negative and lead 1 is negative. What does that mean? It means that there is no way that the cardiac axis is at this area. Okay. So where could that be? Let's take the first 90 degrees angle. Let's talk about first lead 2. Where would the cardiac axis be to have a negative lead 2? This is the line of lead 2. So we should see a 90 degrees angle from here and a 90 degrees angle from here. Okay. So anything like anything away from this 90 degrees angle, anything here, 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 would give us a negative lead 2, which is 180 degrees from this line. So if we form this circle, anything in this circle would give us a positive lead 2. Anything in this semicircle would give us a negative lead 2. So that's the first question answered. The second one is when lead 1 is negative, what does that mean? It means that if we cut this circle into a half, because this is the line for lead 1, and we have a 90 degrees angle from here, a 90 degrees angle from here, this half circle would be positive for lead 1, this half circle would be negative for lead 1. So we're basically talking about this half of the circle when lead 1 is negative. Now let's take the sum of both negative leads. So we said for lead 1, for lead 2, this half of the circle. For lead 1, it's this half of the circle. So where do you think now the cardiac axis is? It's supposed to overlap both leads because both leads are negative. So if we say that it is, for example, here, this would give us a negative lead 2, but it's going to give us a positive lead 1 because this area is positive for lead 1. So it's not going to be here. What about this area? This area is negative for lead 1, but it's positive for lead 2 because it's even less than 90 degrees of an angle. So it's not going to be here and it's not going to be here. So we're final with this area. This is where the area where you would see a negative lead 1 and a negative lead 2 at the same time. Okay, so someone might ask, I want to say for sure where exactly the line of the cardiac axis be. So for that, we apply the same rules that we have gone with for lead 1 and 2 when we see AVF, lead 3, AVL, and AVR. Anything that is more than 90 degrees of an angle would give us a negative charge. Anything with a less than a 90 degrees angle would give us a positive charge. Okay. Now, basically, they say that this is a no man's land. We rarely see any cardiac axis going this way because usually the SA node travels, the impulse travels from the SA node downwards. So basically, we see them here, but sometimes we might see them in the right side here if there was any significant pathology. Okay, is there any other question before we proceed? Okay. So if R meet in lead 1 and 2 are right axis deviation, if they don't meet, it's left axis deviation. I don't understand what you mean by meet. If R meet in lead 1 and 2, it is considered a right axis deviation. If they don't meet, this is a left axis deviation. If you can just send the question again in a clearer way, I'll be able, inshallah, to answer you. Is there any other question before we proceed? Okay. So moving on to the bundle branch blocks. So basically what happens here is if you are faced with a patient who comes with for example, a myocardial infarction. What a myocardial infarction does is it fibroses some of the cardiac tissue. And that kind of fibrosis forms a scar, and that scar does not transmit any electrical activity. So if this happens, for example, here, if it happens, for example, here, we would be seeing a right bundle branch block, which means that there is a scar tissue here, and it's difficult for the electrical impulse to travel through this scarred tissue. So it goes around it to form an accessory pathways. Those will be small accessory pathways that will overcome this scarred tissue. And for that, when that happens, you will be seeing that the time taken for the right ventricle to form its full charge that would cause a contraction would be way more time consuming than the time that is taken usually for the left ventricle. And that's when we start seeing the RSR wave. First, we used to see a single R wave, and that's when both of the ventricles contract simultaneously. But when there is a delay in one of those ventricles to contract because of such a problem, and then we would see the first R wave forming normally, and then the delayed R wave comes up next. And that's when we see the rabbit ears or the RSR wave. Okay, so how do we know what kind of abundant branch are we faced with that is blocked? One of the things that we might see there is a change in the normal axis. So when we see that the sum of all contractions and the sum of the directions of all the electrical impulse comes down to this normal axis, normally when we take the sum of the right bundle branch, left anterior fascicle, and the posterior fascicle of the left bundle branch, that moves into a left axis deviation if the left anterior fascicle is blocked. If we see that the right bundle branch is only blocked, we know that the magnitude of electrical activity going to the right ventricle is way less than the one going to the left ventricle. So that shouldn't change the normal cardiac axis, because basically the normal cardiac axis is going from the start to the left side. It's not going to the right side. So blocking the right bundle branch should not usually change the axis. But when you see that it is going downwards, the reason why it's going left and downwards is the element of direction in both the anterior and the posterior fascicle. So if one of them is blocked, that would also change the direction of the axis. If the left anterior descending is blocked by itself, or if there was a bifascicular block where two bundles are blocked, you will see a left axis deviation because the element of that downwards direction have been weakened by the block of the left anterior fascicle. So what we see is, first of all, where would we see the right and left bundle branch blocks? Basically, we see the changes, the double R waves, we see them at the area that is responsible for the delay. So if we say this is the heart, and there was a left bundle branch block, we're supposed to see the RSR at this area. So any lead that is facing the left side of the heart should be forming the M wave. And at the same time, if this is a right, if it's a right bundle branch block, and the block is here, any lead that is here, it should be forming the RSR wave. So when determining what kind of a bundle branch block we're faced with, always look at the leads that are seeing this kind of change. So in the right bundle branch block, we see that V1, which represents one of the leads that are facing the right side of the heart, you'll be seeing the RSR wave in it. And at the same time, we'll be seeing an inverted T wave at that area. We don't see that in V6 or the left leads, which is represented here by the V6. In the left bundle branch block, we see these similar changes in V6. So we have the M wave and we have the inverted T wave. Here we see that the T wave is everted, which is normally shaped in V1 in the right leads of the left bundle branch block. So basically what I want you to always keep an eye on is where exactly do you see the M wave and the T wave inversion. Those two changes would tell you exactly what kind of a bundle branch block you're faced with. If you see those two changes in the right leads, this is a right bundle branch block. If you see those two changes in the left leads, like here and here, this is a left bundle branch block. Okay? So what kind of a bundle branch block do you see here? Okay, excellent. So what we're seeing here is the M wave here, here, and here, and those are seen in one of the left-sided leads. We can also see that there is a T wave inversion. And you can also see it here clearly in AVL, which is also one of the left leads. You can see that there is a T wave inversion. So when we say that we're looking for the M wave and the T wave inversion, we look at all the left-sided leads in order to say if we are seeing a left bundle branch block or a right bundle branch block. Okay, what about here? So basically this is a right bundle branch block. You can see that V1, V2, and V3 are all leads that are placed at the right side of the heart. And you can see the both changes in all of those three leads, the M wave and the T wave inversion, M wave and T wave inversion, M wave and T wave inversion. You can see also here. Okay, so this is a right bundle branch block. Okay. And this also is another example. You can see the M wave here. You can also see it here. And you can also see it in lead 3. So those all represent the right side of the heart. And that's where you see also the T wave inversion here. So that is a right bundle branch block. That's another example. You can see that AVL is usually placed at the left side of the heart. V5, V6 are also at the left side of the heart. You can see the M wave here with the T wave inversion, M wave here with the T wave inversion, M wave with a T wave inversion. So this is a left bundle branch block. Okay. So. All right, any question about this before we move on to the cardiac ischemia? Okay. So let's move on to the cardiac ischemia or myocardial infarction. Basically, what we will be talking about is the ST segment elevation myocardial infarction, because that's where we majorly see the ECG changes. So what we see usually is an evolution of the MI. There are stages where we see the changes in the MI starting from the beginning of the insult until days after the insult. What we see first is the ST segment elevation. This is how it's normally shaped. And then we can see that the isoelectric line here does not match the level of the ST segment. And you can see that it's going higher and higher with time. And that's what we don't see in a normal ECG pattern. So there is a ST segment elevation as a first step. The second step is the formation of the Q wave. And then it's the T wave inversion. Now keep in mind that the Q wave can be physiologically found in some patients. Usually the Q wave, the physiological Q wave is usually small in magnitude. It doesn't form any large amplitude. The second thing is that usually the Q wave is found in healthy patients without any preceding history of cardiac insult. If you have a baseline ECG for a patient and then the patient comes with chest pain and you don't see a Q wave in the previous ECG and now you see a Q wave, this means that you are seeing a pathological Q wave. And usually the Q wave does not disappear after the cardiac insult, where the ST segment elevation goes back to normal and the T wave inversion also with time go back to normal. So this is the only permanent change that we might see. So if a patient comes with a past history of MI about a year ago, you might continually to see the presence of the Q wave regardless of the presence of any T wave inversion or ST segment elevation. Now, where do we see the insults? Now, you've heard so many times anterior MI, posterior MI, lateral MI, or inferolateral MI. So how do we determine what kind of a site that had been affected by this kind of myocardial infarction? Basically, what we do is that we look at the leads that have seen the changes. So when we talk about those changes, the ST segment elevation, the Q wave formation, and the T wave inversion, usually we would be seeing them in some of the leads, not all the leads. So for the inferior MI, we will be seeing that in all the leads that are placed in the inferior side of the heart, which is lead 2, 3, and AVF. Let's go back to the picture where we have the position of all the leads, and we can just, if you can picture this by yourself, you'll be able to say where exactly is the MI without going back to this kind of table. So if we talk about a lateral MI, the leads that are in concern is AVL, lead 1, V5, and V6, because they're all looking at the lateral side of the heart. If we want to talk about a case of inferior MI, basically we're talking about this area. So we're looking at lead 3, AVF, and lead 2. So we will be seeing the changes that we've discussed in those leads. When we talk about an anterior MI, an anterior MI is usually represented by V3, V2, and V4, and sometimes also V5. Okay. We have also a septal MI, which is the interventricular septum. Usually this is represented by V2 and V3. And we have anterior septal MI, where it is represented by V3 and V4. And also V1 can be considered as part of the septal MI. So if you can picture this kind of drawing, you'll be able to say where you'll be expecting the changes to be if you're faced with a certain type of myocardial infarction. Okay, so going to recall this again, inferior MI, we looked at V2, 3, and AVF. Lateral MI, we're looking at lead 1, AVL, V5, and V6. Anterior MI is V3 and V4. Septal MI is V1 and V2. And this is where we see them in the ECG. So again, when we look at the lateral MI, we look at the lateral leads, 1, AVL, V5, and V6. When we look at the anterior MI, we look at V3 and V4. When we look at the septal MI, it's V1 and V2. And when we look at the inferior MI, we look at 2, 3, and AVF, which are all located at the inferior side of the heart. And when you do that, you'll be able to know what kind of coronary artery that had been affected and blocked, which have been complicated with this kind of myocardial infarction. So if you have a blockage in the right coronary artery, you should be expecting either an inferior MI or a posterior MI, because that is also covered and supplied by the right coronary artery. If you have a blockage in the left circumflex artery, you might be dealing with a lateral MI. If you're talking about a left anterior descending artery, you might be seeing either a lateral or an anterior MI, because it is both, they are both covered by the lateral left anterior descending artery. So knowing these blood supplies to different sides of the heart might let you understand how exactly this kind of insult had happened to the cardiac muscle. So if somebody can tell me now, where exactly is this myocardial infarction? Can you locate it based on this ECG? Excellent. Okay, so what we see here is an ST segment elevation in AVL, in V2. AVL represents one of the lateral leads. V2, V3, V4, and V5 represent the anterior leads, and then going to V5 and also V6 in the lateral leads. So what we're seeing here is an anterior lateral MI, where we see it covering the anterior leads and also the lateral leads. What about here? Good. So most of you have picked up that there is an ST segment elevation in lead 2, 3, and AVF, which represents the inferior part of the cardiac muscle, which means that this is an inferior MI. But at the same time, you can see that there is an ST segment elevation in V5 and V6, which might be also a lateral MI. So you can say that this is an inferolateral MI, but basically the majority of these ischemic insults comes at the at the inferior side of the heart, and that's why you see the magnitude of the ST elevation greater in the inferior leads than the lateral leads. Okay. So this is also another example. You can see that there is a significant ST elevation in V2, V3, V4, V5, and V6. What does that mean? This means that this is an anterior-lateral MI. Okay. So what do you think is the pathology here? So this ECG could be for a patient, like a 50 years old, with a history of myocardial infarction 2 years ago. So we don't see any ST segment elevation, we don't see any T wave inversion, but what we see here is the Q wave that you can see in different sites of the ECG strip. So this could possibly be an old Q wave because of a previous cardiac insult. How about this one here? What do you think is the problem in this ECG? Okay, so there are mixed answers here. Basically, we're looking at this ECG, and this is a real-life ECG. Nobody would tell you that we will be expecting an MI pattern here with an ST elevation. You have to be looking at the steps that we've talked about and take them step by step. If you do that, you'll notice that there is some T wave inversion here, which might represent a resolving MI, where the ST segment elevation had resolved, but the T wave inversion continued to persist for some time. Has not resolved yet. And the second thing that you might look at, now I'm just going through it, I'm picking up things randomly from this ECG, but what you're supposed to do is take it step by step, go through the 3 R's and then the 3 C's and then the 2 T's, and then you'll be able to find out more information about the problems that you might see here. You can see also that the electrical charge of lead 2 is negative here, which means what? And we can also see that lead 1 is positive. So if lead 1 is positive and lead 2 is negative, what does that mean? It means that the charge is moving away from lead 2. If we say that lead 2 is at the right side of the heart, lead 1 is at the left side of the heart. So if the charge is moving away from lead 2, which means it's moving away from the right side of the heart, it is basically going towards the left side of the heart. So that means that this is a left axis deviation. One other pathology that we can see here is the marked high amplitude of the R wave that we can see in these leads. And usually we see that with ventricular hypertrophy. Okay, so is there any question regarding what had we previously talked about before we move on to the last section of this workshop? So there's a question about in left bundle branch block, is the AVL changing? Yes, because in left bundle branch block, the M wave or the RSR wave or the bunny ear shaped and the T wave inversion is seen in the left leads, and AVL is one of those leads. Okay, so there's a question, if I want to read an ECG and put the diagnosis, should I just focus on reading lead 1, 2, and 3, and then seeing the other leads or not? Okay, so basically, some of the changes, you might see them in some leads, and then you might not see other leads with those changes. When you take at least 3 leads, regardless of those leads, whether it's lead 1, 2, and 3, or any other 3 leads like AVR, AVL, and AVF, or V1 to V5. So the most important thing to do is to take leads that are away from each other. Don't take like 3 lateral leads and omit the rest. Try to take leads that might cover different regions in the heart. If you see any pathology in one of them, that's when you should be digging into the other leads. The other point that you have to keep in mind is that when you see a change in a single lead and you don't see the change in any other lead, that could be a machine error. So keep in mind that most of the changes that you see, you don't usually see them in one lead. You have to see them in more than one lead to say that these are significant changes. And this is the reason why you should be scanning the strip back and forth to see if there's any changes that correlate with different regions or different leads. Okay, so moving on to the last section, we'll talk about arrhythmias. Now, in the arrhythmias, we can divide them anatomically into atrial arrhythmias, junctional arrhythmias, and ventricular arrhythmias. We'll start with the atrial arrhythmias. We have the premature atrial contractions, atrial fibrillation, and atrial flutter, going down to the junctional tachycardia and the WVW syndrome. And then the PVC is premature ventricular contractions, ventricular tachycardia, VFib, ventricular fibrillation, and torsade de pointe. So the PACs is something that you would commonly see in the ER when you're doing an ECG for patients. It usually occurs when another region of the atria depolarizes. That is not considered as a pathological issue. It might come and go with in different patients. So it is not considered something that is required to be treated unless. So when you see it once or twice in the ECG, you can just say that this is a atrial contraction that does not need any intervention. The way we see that is we see that another region of the atria depolarizes before the SA node, and that is seen in this ECG strip. Now, when you look at this ECG strip, the first thing that you might think is a problem is this gap. And for that, you might say that this is a skipped beat, where actually this is not the problem. The problem is these P waves. Because you can see, if you look at those three R waves, you can see that there is a regular rhythm between those three. But you see that this one, like for example, we have here half a square, 1, 2, 3, 4. So there's 4.5 squares here, there's 4.5 squares here. But if you can see here, there's about 2.5 squares here, and there's about 2.5 squares here, which means that this P wave had come prematurely, and this P wave had come prematurely. So it came already, it caused the contraction, it went down to the ventricles, and it caused the QRS complex. And that same thing happened here. But due to this premature beat, there was a delay before forming a proper beat from the SA node again. And that's the same thing happened here. So when you look at it, you might think that there's a full gap here and there's a skipped beat, but when you look at the intervals between the RR waves, you would see that this is normal, this is normal, this is normal, and those two are the abnormal ones. And those two have caused this kind of delay. Okay? Now moving to the atrial fibrillation. The atrial fibrillation is commonly seen in many patients with different pathologies. Usually what we see in the ECG is the absence of a P wave and an irregular ventricular rate. So basically what happens is that the atria start fibrillating. When it fibrillates, it means that it's not contracting fully. If it's not contracting, it's not going to be forming any P waves that we see in the ECG. And for that, we start seeing absence of the P wave in the ECG. The second problem is because we don't have any proper contractions from the atrium, that's why we don't see any regular cardiac ventricular beats. And for that, we have always seen those two changes. The first thing is that we don't see any P waves. The second thing is that the ventricular rate or the R waves are not seen on regular pace. Okay, so what we see here is the absence, if I can just enlarge this. Okay, you can see here that there is an isoelectric line followed directly by a QRS complex. You can also see this one here. There is an isoelectric line followed by a QRS complex, isoelectric line followed by a QRS complex. So this is the first change. We don't see any P waves, absence of P waves. The second change that we see, you can see the space between the two S waves here, compared to the space here, compared to the space here. You would know that there is an irregularity seen in the ventricular contractions. So the first change is absence of the P waves. The second change is an irregular ventricular rate. If you see those two changes throughout the strip, you would diagnose the patient with atrial fibrillation. Now, atrial flutter is a re-entrant rhythm. Usually it's a fast rhythm with a rate of about 280 to 300 beats per minute. And what we usually see is a sawtooth shape. And this is the way we see it. We see that there is an amplitude for the atrial activity, but because the rate is so fast, it doesn't always form a QRS complex following it. Now, in terms of treatment, atrial fibrillation and atrial flutter are treated in a similar fashion, especially if the patient is unstable. Okay, so moving on to the junctional tachycardia. See if there's any question. Can ECG detect seizures and how does it look like? Okay, so let's just answer this question first. Usually, if the patient is not steady on the bed and the ECG recording is on, you might see different waves and different activities, which does not reflect the cardiac muscle activity. It may reflect the chest wall muscle activities. So if the patient is having seizure, you might not be able to detect or record a proper ECG. Is that the same thing goes if the patient was moving on the bed. So it's always recommended for patients to stay still while we are recording the ECG activity, because any kind of activity for the muscles that are covering the chest wall might form some changes or errors in the ECG. So yes, the ECG will change the way we see ECGs. The seizure will change the way we see ECGs. So it is not advisable for us to do ECGs while the patient is seizing. Okay, so junctional tachycardia means that the tachycardia has started from the AV node, which is the junction between the atria and the ventricles. It is associated with impulses in a focus in the region of the AV node due to AV dissociation. What we see on ECG is that the P waves may be inverted in leads 2, 3, and AVF, or it may not be visible. And there would be narrow, complex QRS shapes. We'll talk about the shapes of the QRS complexes in a minute, but I want you to understand why sometimes we don't see the P wave and why do we always see the QRS complex in a narrow shape. So if we can just quickly go back to this picture. Okay, so when we say that this is a junctional tachycardia, it means that the pathology is starting from here. Now, if the pathology starts here, what's going to happen to the QRS complex that follows? It should be normal. It should be normally shaped. Why? Because it's going to follow the same normal pathway that it usually takes. So there wouldn't be any problem here. So the QRS complex could be a narrow or a normally shaped QRS complex, which is not going to be a problem. The problem is what's in here and what's above it. So that's why if the impulse starts from here, we might not see any SA node. Or we might see that the P wave is inverted. And why is that? Because usually the direction of the contraction will be going downwards, but if the impulse comes from here, the direction will be going upwards to fill up the atria to form the contraction. So there might be a contraction here, but the direction of the current is opposite to what we usually see. So we might not see any P wave, or we might see an inverted P wave because of the direction of the current. but anything that is below the AV node should look as normal as it used to be. There wouldn't be any problem in that. Okay, so this is what we see in the ECG strip. We can see that there is an absence of P wave with a narrow complex QRS. Now, somebody might ask, isn't this the same thing that we used to see in atrial fibrillation? Absence of P wave and a normal QRS complex. So what is the difference between a junctional tachycardia and atrial fibrillation? How can we say that this is an ECG of a junctional tachycardia and it's not an ECG of atrial fibrillation? Can somebody answer this question, please? Excellent. So the major difference is not the absence of the QRS complex, of the P wave, but it's the regularity of the QRS complexes. What we see in atrial fibrillation is because there is no significant contraction forming from the atria going down to the ventricles, so the rate of the ventricular contractions varies from one cycle to the other, where in junctional tachycardia, there is a fixed rate starting from the AV node going down to the ventricles. So there we would see a regular ventricular contraction pattern in junctional tachycardia. Okay, moving on to another junctional arrhythmia, which is the WPW syndrome, Wolff-Parkinson-White syndrome, where we usually see an accessory pathway. Now, usually what we see in a normal conduction is that the activity starts from the SA node, goes to the AV node, and then it goes through the Purkinje fibers to the ventricular walls and forms the ventricular contraction. But in the WBW, we find that there is an accessory pathway that is formed, and that causes a loop. And this kind of loop is seen in the ECG in the form of a delta wave. Now, this accessory pathway is called the bundle of Kent. And if it's there, it might cause some activity, and this kind of loop might cause a slight slope in the direction of the beginning of the R wave. So this is what we normally see the QRS complex, and this is how we see it with the delta wave, because of the activity that starts at the level of the AV node, which is the area that is represented by the PR interval. So what do we see in ECG? We see a short PR interval. The reason for that is that when we start measuring the PR interval, we start usually from the beginning of the beginning of the P wave until it's the beginning of the R wave. So when we look at it here, we also say that the beginning of the P is here, but the beginning of the R is not here anymore. It's going to be here. So this is why we see a shortened PR interval, where we usually see it longer than that. At the same time, for the same reason, we see a widened QRS complex, because we're going to be counting and measuring the QR complex from here instead of from here, like how we used to. So there will be a widened QRS complex and a narrowed PR interval. So one is taken from the other. And also the slurred upstroke that we see because of the delta wave. So this is an example of a WBW syndrome, and if you can look closely, you might notice the delta wave in different sites in this ECG. You can see it here, you can see it here, and you can also see it here, you can see it here, you can see it at different sites of the ECG. Now, the three changes that we see is a shortened PR interval, a prolonged QRS complex interval or a widened QRS complex, and a slope that represents the delta wave. Now we will conclude with the ventricular arrhythmias. Is there any question? Okay. So we'll conclude with the ventricular arrhythmias. We'll start with the premature ventricular contraction, which is in a way similar to the premature atrial contraction, where we see an extra beat forming from the atria. Here we see the heartbeat initiated at the site of the Purkinje fibers rather than going down from the SA node as we usually see. And for that, we see the shape of the QRS a lot distorted than how we usually see it. This is a normally shaped QRS complex, and this is a distorted QRS complex that is happening because of the abnormal site of the impulse that had formed the ventricular contraction. Now, if you want to understand why do we see this distorted shape in the ECG when we have a premature ventricular contraction, let's just quickly draw a heart. So if I'm looking at the heart from here, and I see that the impulse goes through the Purkinje fibers to the walls, forming the contractions, I will always see it in the same way I've been seeing it from the beginning. But if the contraction starts, for example, from here, the impulse starts from here, then there will be a filling here, and then it's going to be like this. It's going to be going at different areas, but not through the same pathway that I'm used to. That's why the amplitude of the impulse that I'm going to be seeing would look different than the way I used to see it before. And that's why the shape of the QRS complex would be distorted. It will not look the same as I used to see it. Now, for the ventricular tachycardia, we can divide it into monomorphic and polymorphic ventricular tachycardia. Now, in the monomorphic, from its name, it means that there is a single morphology for all the QRS complexes. This is usually caused by an increased automaticity of a single point or a re-entry circuit within the ventricle, which means that there will be a change. What we see here, what we see, for example, here, is an abnormally shaped QRS complex. But what we see in ventricular tachycardia is that we're going to be seeing the same shape every time, which means that the source of the impulse would be the same every time. So it's either a re-entry circuit or an increased automaticity of a single point. Now, the most common cause of that is myocardial infarction. And why is that? Because with myocardial infarction, we would see, like, for example, if there is a scarred tissue here, there will be a circuit that goes around this scar tissue, because this scar tissue cannot conduct any electrical impulse. And for that, the shape of the QRS complex would be distorted, but it would always look the same, because the electrical current would always take this abnormal pathway. In polymorphic ventricular tachycardia, on the other hand, it is mostly caused by abnormalities in the ventricular muscle repolarization. This is usually seen when we see some electrolyte disturbances in the body that causes a change in the contractility of the cardiac muscle. And for that, we see that the cardiac muscle had been excited at different sites every time. And this is why every single impulse that is formed from a different site would give us a differently shaped QRS complex. So every time we see a QRS complex, it would not look the same as the one preceding it or the one following it. Why? Because the source would be different. And we only see that when the whole cardiac muscle have been impaired because of the changes in like something metabolic, like the electrolyte changes. And with that, we see some QT prolongation, which may be congenital in some of the metabolic errors, or acquired if there was any changes in the electrolytes. So this is the way we see the monomorphic ventricular tachycardia. You can see that all the QRS complexes, although they don't look normal, but they all look the same. They all look the same, which means that they are all coming from the same spot every time, or they're taking the same pathway every time. This is how we see the polymorphic ventricular tachycardia, and this is how you see that the QRS complexes in a single lead, they all look different. They're changing throughout the ECG strip. You can see it also here and here. The amplitude is changing, the shape is changing, and the interval is also changing. Now, when we talk about ventricular fibrillation, that in term is similar to atrial fibrillation, where the ventricles quiver and shake, they don't fully contract, and that causes no pulse or absence of pulse for the patient, because the ventricles are not contracting, so the blood is not moving throughout the circulation. Without treatment, this is a death case. What we see there is unformed QRS complexes without any clear P-waves, and we don't see any full contractility of the QRS complexes. And this is the way we see it. Now, the difference between ventricular fibrillation and ventricular tachycardia is that the amplitude of the QRS complexes is way higher in ventricular tachycardia because it's forming a full ventricular contraction. But in ventricular fibrillation, the ventricles are only shaking. They're not forming a full ventricular contraction. And for that, the patient would be pulseless, and the patient might die if not if this case is not treated abruptly. Now, another differential diagnosis for ventricular fibrillation is torsade de Pointes, and that is a distinctive form of polymorphic ventricular tachycardia, where there is a gradual change in the amplitude and twisting of the QRS complex around the isoelectric line. Now, when you see it, there is an isoelectric line that goes through the strip, where you see that the amplitude goes up, and then it goes down with time, and then it goes up again, and then it goes down. So it forms waves of changing amplitude throughout the strip, where the isoelectric line is seen in the middle of the strip. In ECG, we see drastic rotation of the heart's electrical axis, prolonged QT interval preceded by long and short PR and RR intervals, and that could be triggered by some of the premature ventricular contractions. So the question comes, how do we say, when would we say that this is a torsade de Pointes, and when would we say that this is a ventricular fibrillation? Now you can see here that there is some change in the amplitude of the electrical activity in the ventricles. So when would we say, why have we distinguished these two, and we've said that ventricular fibrillation is different than torsade de Pointes? You can see that in torsade de Pointes there was an isoelectric line that was going through the ventricular activity. We don't see that here. If we look at the isoelectric line here, it wouldn't be straight like this, but it would be going up and down and up and down, because the isoelectric line is supposed to be in the middle of the ventricular activity between the positive and the negative charges. So for that, we cannot say that this is torsade de pointe because the isoelectric line is not steady. And if you can compare it to this one here, you can put a straight line throughout the activity, and you can say that it goes up and down across the isoelectric line, which is not the case with ventricular fibrillation. And with this, I conclude, and I thank you very much. And if there's any questions, please, you're welcome to ask them now.
Dr. Badr, thank you for your presentation. Anybody has a question for Dr. Badr? Dr. Badr?
Yes.
Yeah.
Yes, I can hear you. If there's any question, you're welcome to ask them now. Okay. Thank you, Khuru. This is a really good question. When do we use more than those leads? When do we use the 15 or the 18 leads? Now, this is basically done when we talk about the possibility of posterior MI. Let's just go back to now, you remember that we've said that there is a posterior MI, which is one of the pathologies that we might face in the ECG. Now, what happens is that you can see that we start with V1, V2, V3, V4 until V6, and there is V7, V8, V9, V10 until V12 at the posterior side of the chest wall. We usually do that if we see some changes in the anterior leads, okay? So we call them reciprocal changes. What do we mean by reciprocal changes? When we talked about the, like for example, the anterior MI. In anterior MI, we see some T-wave inversion, we see some ST elevation in the anterior leads. But if we see a reciprocal change means that if you put a mirror in front of those changes, you would see the opposite of those changes, which means that we're going to be seeing an ST depression followed by an everted T wave, which is the opposite of what we're expecting if this is an anterior MI. If we see that in the anterior leads, we should go for the posterior leads. We should place them, and we're going to be seeing the ST elevation and the T wave inversion in the posterior leads as the way we see them in the anterior leads, if that was an anterior MI. Thank you for the question.
There is another question, Dr. Badr. You can see it.
Okay, so in the first degree heart block, we see a fixed prolongation of the PR interval. In a premature beat, we don't see the premature beat with every beat. We can see them like once or twice in the whole strip. We don't have to see them with every beat, which is different from the first degree heart block, where we see the prolongation with every beat.
Thank you, Dr. Badr, for your presentation, and thank for all participants in this meeting. Anything you need to say, Dr. Badr, before the end of this meeting?
Okay, thank you very much for everyone, and I hope you get the benefit of this workshop, and I hope from now on you will all be able to put your feet on the first steps of reading the ECGs properly. And please remember to take your time reading the ECGs so you wouldn't be missing some of the important changes that you might miss them if you just scan through the ECG without going on a systematic method.
Thank you, Dr. Badr. Allah يعطيكم العافية على حضوركم. إن شاء الله the presentation and the recording also will be sent via your registered email بإذن الله. تصبحون على خير، وإن شاء الله لنا لقاءات أخرى إن شاء الله بالأيام القادمة. شكرا دكتور بدر، الله يعطيك العافية. مع السلامة.